I am.
Meeting is being recorded.
Yep, so the meeting is going to be recorded. I know there is a couple of families that emailed me at least and were like, oh, we can't attend, but we definitely want to be part of it. So
Just say got it.
Rista,
I
you
want to try to
froze.
make these
You
as
froze completely, Rista. Whatever you just said got lost.
no. Can you hear me now?
Yes.
All right, I won't move my computer. Okay. All right, so couple of housekeeping things. I want to make these as interactive as possible. There are a couple of places during the presentation that are designed for dialogue, so you'll see that. But feel free to either put questions on the chat or use that little hand that raises its hands, that Zoom hand, if you have any questions, and we'll try to address every question. If I don't have an answer, I will take that question to whoever has an answer, and I will email you back with that. So let's hope this works. I'm going to share, and we are going to do the slideshow. Okay. Hold on. Present online. I don't know if I'm doing it right, but okay.
Rista, you might want to go to start slideshow from beginning.
Yeah, from the beginning, right? There we
Yes.
are. Thank you. Here we are. Okay, so this is actually an introductory seminar about for a series of educational meetings that we are going to have, which is free for families of clients that are enrolled on our CRS.
You're freezing on us again.
We can't hear you.
Would benefit from this.
Okay.
Am I back or am I frozen again?
You're back.
Okay. I will try not to move, but you're doing a very good job keeping me in the place that I need to be. But this is just a very introductory seminar, and it's just to talk about mental illness in general and to let you know a little bit of our approach at CRS and how we see mental illness when we intervene with our clients. But it's certainly something that hopefully will help you have this approach maybe with your family members. So the first thing is, what is mental illness? And at the very basic level is just a dysfunction of a human organ, in this case, our brain, right? Like when you think about an illness, if you have heart disease, you're talking about a heart not working properly. You might have atrial fibrillation, or you might have congestive heart failure. Either way, or other less severe complications or illnesses that can be caused because your heart is not working properly. Same thing if you talk about your lungs, right? You might be diagnosed with asthma or with COPD or with any other respiratory illness, and that's because your lungs are not doing what they're supposed to be doing for your body. When you think about mental illness, you're thinking along the same lines. You're thinking about your brain not doing certain things that it was designed to do. So in the case of mental illness, I'm going to go into more detail in the following slides. We're talking about either a problem with perception, right? And you might have a family member that might have presented in the past or even now with hallucinations, right? Like their visual perception or their auditory perception is not the same as our perception. They might be hearing things that are not there, they're seeing things that are not there, even having sensory experiences that are again, perception, which is one of the functions of the brain, might not be working 100%. Thinking, and that's very common, right? Like a lot of the things that we notice when our family member has a mental illness is, wait, that doesn't make sense, right? What do you mean? What are you saying? You know, or why are you talking about that all the time? But thinking is one of the things that maybe we first notice about what's going on with our family member. What is going on with your thinking? Why are you having those thoughts? Where are you telling me these things? What do they mean? Where do they come from? Mood, obviously, is another thing that the brain regulates, and that is affected by most mental illnesses, but there is in particular mood disorders that we're going to talk about in the following slides that do affect severely mood, right? From being super, super depressed to the point that you cannot function, to being super, super related in a full-blown manic episode in which just like, you know, impulsivity and judgment are out of control, basically. So mood can be affected severely by a mental illness, and behavior, right? Like that's another thing that we notice. First, also, why is my kid not coming home when they're supposed to come home? Why is my kid failing all the classes in college? Why is my spouse, you know, sleeping 15 hours a day? You know, the behavior is one of the things that we notice as not being what it used to be, not being what you would expect for a person the age and you know, the level of functioning that that person had before. So all of those functions are ultimately regulated by the brain. And again, you know, then we have to think of mental illness as ultimately a brain disease, a disease that has changed the functionality of the brain. And that's what we will address in treatment. So how do we treat? Again, and this is a very general overview. Obviously, because it's a brain disease and we're talking about an organ of our body, we are going to try to address that with medications. And there is several things that medications can do depending on the disorder, depending on the neurotransmitters involved in the illness, depending and to use other skills to be able to sorry about that, to be able to create new neural pathways in their brain without the need of medication. Healthy lifestyle, from like, think about someone with bipolar illness, right? If that person with bipolar illness is not sleeping, right? Getting into a regular sleep cycle might just be very helpful and might contribute to this person's health in general improvement, right? Again, think about someone that is in active addiction. Eating is not something that they're doing regularly, or they're eating very poorly, right? Improving your eating habits might contribute to a significant improvement with that person. Education is important, especially for people with severe mental illness, because a lot of these severe mental illness, again, we're going to go into more detail in a bit, but people with thought disorders and mood disorders tend to have a symptom called anosognosia, which basically means they're sick and they don't know it. So these are the people that you might struggle with trying to get into treatment, trying to accept medication, trying to accept even like to talk to a therapist or to do anything basic for themselves because they don't know they're sick. So the more education that we can do and constantly remind them of symptoms and how to address them, the more they will have the tools, or at least I want to say the red flags for themselves to intervene eventually, for you know, for them to be more independent on catching up what's going on with the mental illness when it exacerbates. Job training and coaching, there is a lot of actually research studies on this, and this has to do a lot with you know, client-centered care. One of the things that it's been researched and there is a lot of outcome studies on is like when you do treatment plans with clients, if the client is the one designing the treatment plan, if they are setting up the goals themselves, they're more likely to achieve those goals and to stick to that treatment plan. So part of that is like, if you talk to even with the client that is the most uninsightful and everything is, I still, you know, if you ask them, well, what are your goals? They might say, I want to have a job, or, you know, I want to have a partner or a, you know, significant other, or the things that we all want. And if that treatment plan is designed that way, okay, well, you maybe want to have a job. How do we get there, right? And that might include working on life skills, getting into a regular sleep-wake cycle, you know, practicing assertiveness, and all these things that you know might help them with actually getting a job, but also help them improve in their mental health. Or even like, you know, if I take my medication, I will probably not stay awake all day and be tired in the morning and be at risk of being fired from my relationships. Are things that are very commonly goals of everyone, and certainly goals of our clients. And we can set our goals towards that. We have a better chance of being successful achieving those goals. Peer support, there's been a lot of research, a lot of programs are implementing adding peer supports to all levels of care. I think on Monday, I was on a sort of like conversation or a seminar with the Department of Mental Health. And one of the things that they're doing right now, at least in Connecticut, is adding peer support positions to all their levels of care. Because they are seeing the research that, you know, again, justifies the need of having people with lived experience as part of the providers for their clients. We do have, I would want to say at CRS, a very strong peer support program, from having peers in any of the residential programs to having our apprenticeship program, which some of your sons and daughters are involved in, you know, and that's a perfect opportunity to, again, work together with people that has life experience in a healthy kind of setting, in a healthy environment. So that's also well supported by research. And of course, psychotherapy, which again, you know, you have a more traditional psychotherapy, but depending on the condition, you might have more creative psychotherapy, but definitely there are like so many approaches in psychotherapy these days that there is something that will work for anyone. So that's an overview. So the other thing, and I'm not sure I'm going to go through all these slides. You're going to get, you know, this information anyway. But in general, what I want you to get from this slide is that I tend not to want to talk about diagnosis as a concrete diagnosis, or like, you know, you have bipolar 1, most recent episode, depressed with psychotic features, which you might have, and that's the diagnosis that your psychiatrist gave you. But in general, I think these clusters of disorders give you more of an understanding of what is the sort of area of the brain or the function of the brain that is being affected by this mental illness. It's especially important for young adults because let's just talk about mood disorders, right? Diagnosis evolve. And if you've had a young adult with a mental illness for a while, you know that. Your young adult at age 17 might have been diagnosed with depression, right? And by age 20, they're diagnosed with bipolar. And by age 23, some other psychiatrist tells you your young adult has schizoaffective disorder. And you're like, well, what does he have? Does he have the 3? Does he have the 1? Which one is the diagnosis? So what they're telling you is the picture of your family member at that particular time that they are assessing him or her, right? So they're telling you what's going on when they're meeting with that person. They're not telling you on what's going on lifelong. And that's why diagnosis kind of change. But in general, if you have a mood disorder, for example, you will have symptoms that refer to an alteration of your emotional state. And that can remain as a depressive disorder for a lifetime, which is a depressive disorder will be a mood disorder, or can change into a bipolar disorder of some kind, right? It could be bipolar 2, that which will manifest more with like depressive episodes and episodes of irritability. It can be bipolar 1, which is depressive episodes and episodes of mania. It can be a cyclotimic mood disorder, which is like you never get manic enough to be diagnosed with mania or depressed enough to be diagnosed with depressed, but you go up and down all the time. So do you care too much about what it is? Yes, in the moment, because medication might have, the conversation that you have about medications might affect the choice of medication, for example, that the psychiatrist has at that particular moment that they're assessing your family member. But what I think it's important to retain, or important, has a mood disorder and a thought disorder. So I can expect that regardless of what's called on that particular moment, I can expect symptoms of mood dysregulation and symptoms of, thought distortion, because those are the things that my family member has. If my family member has a personality disorder, I can predict that there's going to be very rigid patterns of behaviors, very rigid things that happen all the time that are particularly unuseful for them, right? Because we can all be rigid, but if we are able to function, then that might never be diagnosed as a personality disorder. But if you have a very rigid pattern of thinking and behavior, and you can't live independently, and then you can't function like you want to function, if you are not maintaining your relationships, you're not maintaining your employment, then that's a problem. So seeing this as clusters of symptoms helps us be more flexible too when we are hearing different providers at different times during the lifespan of the disorder. Understand that my family member is not necessarily being diagnosed with 4 diagnoses. It's just, their mood is dysregulated and they're now depressed, but they were manic last year. My family member, has a combination of an anxiety disorder, but they also have a pervasive, rigid pattern of thinking and behavior. So they likely have a personality disorder. The other thing that you can do when you see this in these more general terms is like, sometimes people doesn't have a diagnosis, but they certainly have trace of that diagnosis. So, some diagnoses gain popularity at certain time, and they're more diagnosed at certain, when there's more research done about them, or people finds out more that that's happening with a lot of people. And look, let's talk about borderline personality disorder, right? There's a lot of research. There's been a lot of research with trauma and associating it with borderline personality disorder. So people might even, there's Dr. Google these days. So one might go Google and be like, oh, I have that, right? Bottom line is we might have traits of certain personality disorders or certain anxiety disorders. That doesn't mean we have that, but it's important to recognize that those traits are there. So it gives us that flexibility as well. We don't necessarily have to believe that our family member has all of these things, right? But they might have traits of some of that. And that might help treatment. That might help the certain approaches that we have in terms of therapeutic interventions. Because let's say, you don't officially have an anxiety disorder, you have a mood disorder, but you suffer from episodes of anxiety. We can still develop interventions of that treatment plan to address that anxiety and teach skills to manage anxiety, even though you don't have an anxiety disorder, you're not diagnosed with that, but you certainly will benefit from learning those skills when you're in a difficult situation. Before I move on, any questions, any comments about this?
No.
Okay. I'm going to move on, and this is the part when where you have to talk. So this is a discussion question, and this is important because I think as family members of people with serious mental illness, you've all experienced maybe comments or questions about, what is mental illness, what's going on with your son or daughter or family member, what's going on with you if you have, lived experience of a mental illness. And some of those comments or things that are said might be not right or even hurtful sometimes. So I was wondering if any of you want to share a little bit about the things that you hear being said about mental illness, or where it comes from, or these beliefs that might be sometimes off-putting to some of us.
I'll offer a comment to start us, Rista.
Thank you.
I have struggled a little bit with helping my family understand mental illness, and which is surprising because my mother had a mental illness, which everyone seemed to know and understand. So it's just odd. And I think there's sometimes the false impression that either your behavior or your self-care, but something brought it on that you did. And the implication there is that there is something you can do to make it stop. So it's both sides of the same thing.
Yes, absolutely. There is a lot of, for example, if you see someone that is very depressed, unable to get out of bed, missing days at work or at school, the conclusion might be well, if you were only be more organized, or if you just get out of bed and, get yourself together, then you wouldn't be having all these problems, right? This is a product of laziness, not mental illness. Yeah, absolutely. There is a lot of this implying that you can do a lot of things to fix it.
Yep.
You
Yep.
as our dependent, our child, or you as the parent of that child is the one that should get him up or have,
Either way, right? Those are just comments that one hears sometimes. You're right. Sometimes the parent might hear, why don't you just, get them out of bed and send them on their way to school, right? But sometimes, again, people with lived experience will hear those comments, well, I would tell you one personal thing, not really my lived experience, but my daughter does have actually a mental illness, and she was going to college she graduated in 2019, but she was in her junior year and she was quite sick at school. And I was thinking I have to bring her back, but she decided to stay. Brave her. She graduated. Good for her. However, I remember she couldn't get out of bed. She couldn't get to class. And she had a friend that she asked for notes for because it was one of her friends and she needed notes, and she, who knows how many classes she missed. And the friend didn't want to give her the notes at the beginning.
oh, that's too bad.
Sleep late. I want to give you my notes. Why don't you just go to class? So that's a very common thing that can happen to someone with lived experience. This kid, not a kid, this young adult, my daughter was, skillful enough to explain to her friend that she would have loved to wake up in the morning and be bright-eyed and bushy tail in class, and she just couldn't. So she got the notes, but that's just an example of how, people just doesn't know.
Yeah, to follow up on my example of the thinking that you have control, another example, just by way of explanation, is my mother had bipolar, and of course my father had a spousal relationship with her, and whenever he speaks of it, he said comments, she was so manipulative. Which of course she was. I'm not disputing, it's not that he's wrong, but it's as though it were a personal assault, or it was intentional, or it was even like thought through or intent, it was the illness is what it was.
Mm-hmm. Yep. Yeah, sometimes we forget the part where this is, again, a disease of the brain. There is function, there's something that does not work okay.
Right.
And that's what it is. So here we are. So we can hear the mental illness does not exist, right? Which is related to your comment, Shannon, right? Like, this is not a mental illness. If you just get up and get going, you'll be fine, right? Or like, just stop drinking. Like, alcoholics hear that all the time. Well, just don't drink. You'll be fine if you don't drink, right? Not entirely possible when you have the disease of addiction. Mental illness is a normal response to a sick society, meaning, maybe you're not crazy, maybe everyone else is, right? Like maybe there's nothing wrong with you, right? We just don't know how to manage. Maybe you're right, maybe really what you're saying is right, and we are all wrong, which again, might be true to a certain extent. I mean, I always think about these societies, like, in Eastern cultures that are more accepting of mental illness and incorporate the mentally ill person into their culture and welcome them, and they don't even need medication because they're being incorporated so well into their culture. But at the same time, it's almost encouraging denial, right? Oh, there's nothing wrong with you. And sometimes the intervention is needed. Mental illness is caused by external evil force, right? Again, someone did this to you. It's sort of like the parallel to what the Shannon comment, right? You did this to yourself, or someone did this to you, which not true. Again, it's a disorder of the brain. Caused by poor parenting, and that's hurtful, right? But sometimes we hear that from our family members, from other people. Like, well, you didn't do this when they were growing up. If you would, sometimes we think that, right? If I would have done that when they were in 6th grade, right? And again, we're going through the biopsychosocial model, and we'll see that, yes, sometimes what we do does affect the development of a mental illness, but it's certainly poor parenting alone. It's not going to cause anyone's mental illness. Think about twin studies, think about families with different with more than one child, that are all that, you have 4 kids all severely traumatized. One of them develops mental illness, the other ones are fine. Why is that? Because there is not, poor parenting alone does not do it. And the fact that you didn't, pay for camp in 6th grade definitely did not work. And then again, we talked about this one, the mental illness is caused by something that you do. And mental illness is caused by poor family communication. Again, potentially can make it worse, but does it cause it? Not really. All right, this is the biopsychosocial model. The biopsychosocial model tells us that health in general comes as a combination of factors, biological factors, and that's basically your genetics, and your reactivity to stress, your ability to metabolize medications, any kind of other physical illness or disability that you will have, that will contribute to your mental health. Neurochemistry, that, again, if our serotonin reuptake system is not working properly, we just don't have enough serotonin to make those connections and create those pathways in our brain. Like, that's definitely not caused because you didn't go to class. That's what it is. Then there is the psychology, and that has to do more with feelings, with personal beliefs, with emotions. Trauma does play a role here, right? There's certain things that we learn from our traumatic experience and the way that's recorded on our brain. And again, there's going to be a whole session on this. The way that's recorded on our brain is different than what normal experiences are recorded in our brain, and therefore it affects our experience from that point onward. and the social context. Like, again, yes, the family that you grow up in does have a role, but yeah, it also has to do with birth order, when you went to school and what kind of societal context, right? Think about people going to school 10 years ago and people going to school now. Marijuana is legal now, right? So any high schooler can be like, well, I just get a marijuana card and use marijuana. There's there's a different societal context to what's going on. Think about people, maybe going to school or being in the community 20 years ago. There was maybe 30. There was not much of an opioid epidemic, right? But now there's an opioid epidemic. There's opioids everywhere. There's fentanyl around. Drugs are different. Think about all like how culture and society laws have changed, and people growing up and developing on those different cultural settings will have different influences in their mental health and their development. It's, again, just accessibility to substances, accessibility to care, right? You were growing up where most of us grew up, it was very difficult to access any kind of care for a mental illness. It was like the hospital and that's it. Now there are more options. And yeah, that's one of the ways society affects us in a positive way, right? Now you can have your kid in a community integration program like ours, right? Where they can successfully move into independent living in the community, maybe with some supports, maybe with some setbacks, but that didn't exist when we were growing up. That was not even something that you could think of. So again, when you think about mental illness and how it happens, it's a combination of factors. It's a combination of things that come together for a particular person that show up in a particular way. And that it's impossible to predict. It's impossible to predict. Even if you have, a background in your family of bipolar illness, for example, it's impossible to predict that if your kid's going to be bipolar or not. Maybe that's the answer, but again, that's how genetics work. Maybe you'll have a girl, maybe you'll have a boy, maybe your family member will have this trait that comes from the family, maybe they will not. So that's how things work with biology. Again, even with how you assess and internalize certain experiences in life, that will depend on many factors, but that will form your psychology and who you are and society from one year to the other, right? You have the different, again, like I said, birth order, right? You treat your first kid different than your second kid, than your third kid. So that alone will change in the environment. So you cannot say because they grew up in the same household, they're all the same. You were, 25 and never had a kid when you had your first kid, and you were like 35 and were an expert diaper changer by the time you have your third kid. So definitely a different experience. All right. So again, therefore, when we think about treating mental illness, we think about treating it from all these different approaches. From the bio approach, so medication, nutrition, and general physical health. From the psych approach, and that's education. The SAFE program is some sort of education program that is provided in high schools about mental, it's a preventative program, so it's just an example. Education, psychotherapy, teaching coping skills. And again, there is a difference in between psychotherapy, which is basically learning about yourself and learning about change and create new neural pathways in your brain, and learning practical coping skills. When I'm anxious, what breathing exercises do I know to calm myself down? When I'm angry, what are the coping skills that I can use? What are the activities that I can engage on to be less angry? So all of these things combined address your the psych portion. And the social interventions that are so crucial, sometimes overlooked, and especially in prior treatment modalities that were severely overlooked, right? But again, talking about jobs, socializing with peers, participating on advocacy, all of those things were not part of treatment in the past. And then with research, it's clear that incorporating those management of that social environment is important. So thinking about, again, having your own apartment, getting a job, developing relationships with peers, all those things are part of the wellness that it's important for treatment. Okay. I teach my clients, and it's the vulnerability stress model. And it's important because it helps us understand what we have to do to manage our own selves. So part of the genetic predisposition, or sometimes this sort of, I would call it predisposition to creative trauma, is that sometimes we are not, like, think about a scale from 0 to 10. And most of us, when we're calm, we're at 0. When we're like, can't take it, we're at 10. Not all of us are born with that complete scale. Think about it that way. Some people are born with a 5 to 10. So they start at 5. Some people are born with a 3 to 10. So they start at 3. And that means that in order to escalate, they have a lot less time, or a lot less of a window to be able to intervene. So if you have someone that, when they're okay, they're at 5, and they don't want to go to 10, they only have. And teaching that to our clients is important, because I'm like, okay, if you know that you're at baseline, are not at a 0, you're not cool as a cucumber, then what are the skills that we need to use to not get to that 10 when you lose control? So that is something that there's a lot of research done this on personality disorders, and because part of these, like, perversive patterns of behavior because I don't have much to do in between 5 and 10, I tend to be very rigid about what I do. And those patterns are very much established. And sometimes they're very unhealthy. Like, for example, if I don't have much to do to control my anxiety, I might decide that the best way to do it, the quickest way to do it, is to use some drug or to drink alcohol, because that's pretty fast. That'll get me out of 10, right? So, or you might think about self-harm the same way. You might think about other unhealthy things that we might do, or that our family members might do, to deal with this very low variability in between being calm and being not calm. All right. That's pretty much it. I don't know if you guys have any questions. I do have a couple of more slides after this. It's mostly to just let you know what else we're going to be doing in the upcoming weeks, and also if we can add to these your comments or your requests, if you want, for what can we do that can be helpful for your families or for you in terms of education. I see Shannon raising her hand.
Rista, I have a question on that stress vulnerability slide.
Mm-hmm.
I noticed that nowhere on it is controlled substances, drugs,
Mm-hmm.
which is interesting. And I just wonder, what role do drugs play in vulnerability, if any?
Big.
Yes, I mean, well, so in terms of the predisposition, they don't play such a large role, but in terms of what we choose, because they do things to us, it's very common, right? When you think about, again, that person that has the 5 to 10, if they have to pick something quick to fix it, that's one of the first choices. And that's unfortunate because a lot of our family members, because of their mental illness, they do have that very, very high vulnerability, right? And that's how they end up adding to their problem by adding some regular substance use to their illness. So even though they don't cause the predisposition, they're a preferred way to quickly deal with that inability to control things otherwise.
Yeah, okay.
Any other questions, comments, requests? I'm actually particularly interested in those requests.
Well, one thing that we've dealt with in our family is that when our son is not doing well, he tends to not communicate with some members of our family who then, start feeling, kind of taking it personally, even though we know that he's mentally ill. People still feel like, well, maybe he doesn't like me anymore, and maybe we just have questions about how we should interact in that setting.
Mm-hmm.
Because obviously it's due to his mental illness, because the basic relationships are good, but he will just stop talking to people for months on end. So that's been an issue. So I don't know if that's something you were planning to discuss.
I could, and we can probably discuss more, in your own family meetings, but I could. In general, I think that this model, the model that we practice in CRS, is to empower the client to write their own treatment. So I think that, for example, those family members that are still talking could ask, how do you want to address this?
Mm-hmm.
I think that empowering your son to sort of give you the way to do that,
Mm-hmm.
it's probably the first line of action. That's what I would suggest for my kid, for my client. It's like, well, okay, let's use you as an example. Let's say you're the one that is not communicating with him. Like mom, mom called, and mom would really like to hear of how you're doing. I know you haven't been talking to her. How would you like to work on that? How would you like to address that? Should I call mom? Should we call together? Should we prepare to call mom before you call mom? Like, how do you think you can feel comfortable addressing that? Because I think that empowering them to make decisions sometimes will surprise us. Sometimes, and maybe they won't make the decision that we want, but they will make a healthy enough decision that they can manage. And that's important.
Thank you.
You're welcome. And maybe we can go ahead, Liz.
You say they don't talk to other family members. Other family members cut my son and me, my son, off, and there's no getting that to change. Excuse me. I think they need family, and the family keeps, moving on to what's more fun than being with someone that hasn't been a lot of fun to be with. So, I really think that they need family. There are about 10 articles right now in the Times, which I like to read the Times, way back from, what went wrong with mental illness treatment to what words people are using incorrectly, which I tried to use, and now they're saying, no, don't, because instead of saying mental illness, maybe you say mental health, but then it minimizes it, but it is actually your bodily health, which John said is now behavior health. But are you talking to him the way I think this is way too general, but I hope you're talking to him about all these points, because I know that you and I know that they cannot recognize that it's what the real problems are.
Yeah,
that word that I can't pronounce,
agnosognosia. I can barely say it myself. Yes, so we do present this. This is part of the treatment, right? Education is part of the treatment. So we do, I mean, at least I can tell you that during the groups that I run with all of them, I do that stress model at least every other month. I do the biopsychosocial model with them. I do the whole thing about anxiety and how it works in your brain. We do have another psychoeducational thing about meds and how they work and how they help and what's the difference in between developing coping skills and using meds. So we do all these things to educate them. Do we have to repeat them? Yes, we have to repeat them all the time. But I think that it does, some of that information stays, some of that information allows them to think differently about themselves. And it's part of the comprehensive treatment that we were describing. And you're right, Liz, this is very general because this is just an introduction. This is what we want to do. We want to really go into detail into any of these diagnoses. We want to really go into detail about, treatment modalities and things that we suggest or want to, propose as treatment paths for our clients. And a couple of, I like section 3 particularly because it's probably what I've done the longest, right? I've joined sort of the clinician world not so long ago, many years, and I've done advocacy and sort of more administrative work in programs forever. So I think it's important for you as family members to know your resources for advocate, to know how to deal with insurance, to know how to get your kids to learn about these things for when they have to advocate for themselves. But anyway, I try to make this as comprehensive as possible. We're going to try to have speakers come for the medication management module, for the individual and group therapy modalities of treatment, so that you can have a much more comprehensive sort of understanding of how mental illness looks like and how treatment looks like and what are the things that you can do. But I do really appreciate your candid conversation today. I think it's important that we all talk about what's going on with our kids and with us, and that we sort of like try to educate ourselves and learn from each other, right? So hopefully we can continue to do this. Deborah will be sending the information about the upcoming webinars, and we're gonna maybe try to do them hybrid when we can. Shannon.
So this is a very nice layout. This looks really interesting, Rista. And now that you've prompted me, which is helpful, thank you. One for where we are, in our journey. One thing that I would like to learn a little bit more about is maintenance mode. When I don't know if anybody on this call, when they were new parents, read Girlfriend's Guide books. There's the Girlfriend's Guide to the first year, the Girlfriend's Guide to whatever. And then there's the Girlfriend's Guide to Getting Your Groove Back is the last one. And that's what comes to my mind is kind of, what does maintenance look like? What are signs later in a more mature state of the disease that we have, and so like just kind of that stage would be interesting.
No, that's a great idea, and I think that yes, that is that's a lot of education that I know with your son. I hope the STEP program is helping him with that. It's great to see that happening with them, but there's also the fear that it will look like the prior girlfriends.
Yes.
And we don't want that, right?
No.
But yes, no, I think that someone that has grown in the management of their mental illness that he has, could be successful having a relationship. It'll be just a matter of keeping very honest with that relationship, right? Like
Mhm.
make almost like inviting that person to be an ally so that they can be part of effectively part of that support system. But yes, definitely that's a nice module 9 to add to this. And you know what happens after, right? What happens when we are moving forward?
Yeah, yeah.
Right. Well, I would leave a couple of minutes for a last minute questions, but if not, we are done. You're
Thank
welcome.
you.
Thanks so much for joining. And as I said, Deb will be sending out the invitation for the future meetings.
Thank you, Rista.
Thanks,
Thanks,
Rista.
Tanya.
Thanks,
Nice to
thank you
see
very
you.
much.
Bye.
And goodbye.
Bye. I'm trying here.